Hi, Dr. Ngwenya. Today we will be discussing non-melanoma skin cancers. Tell us about this.
Good morning and thank you for the opportunity. Yes, indeed, we'll be speaking about non-melanoma skin cancers, meaning all the skin cancers apart from melanoma. So this would need a succinct understanding of the skin. Now, I won't go elaborate. I think we all know there are 3 layers to the skin. There's the epidermis, of which there are 5 layers in thick skin and 4 layers in thin skin. There's the dermis, and there's the hypodermis. Now, the epidermis, that would be the strata corneum, your strata lucidum, your strata granulosum, spinosum, and basale, which those combined, the spinosum and basale, would form the Malpighian layer. It's called Malpighian after an Italian biologist by the name of Marcello Malpighi, who named that after him. And then you get your dermis. There's the papillary dermis, and then there's your reticular dermis. Therein, you will find these adnexal structures, your Pacinian corpuscles, Meckel. You will find your glands there, your sebaceous gland, your apocrine, acrine, hair follicles. So that's where we'll find most of these. And then we go down to the area called the hypodermis, or the subcutaneous tissue, as the 3rd layer before a fascial layer. Now, any cancer from these structures other than melanoma. Remember, we said melanoma is the cancer that comes from these cells called melanocytes that differentiate from these melanoblasts, from neural crest cells, go to the eye, to the skin, to the hair, and they differentiate into the melanocytes with this dendrites. So any cancer from that is melanoma. Now, we are going to talk about all other cancers. These will be, the most common of which is your basal cell carcinoma, your squamous cell carcinoma, which follows, and then these cancers called adnexal cancers, because these are skin cancers within that area. So that includes them.
So what are the risk factors for getting these skin cancers?
Look, whenever we talk about risk factors, what I want you to always do is divide this into host and environment. Host factors being the patient themselves, the individual, and then environmental factors. Now, when we speak about host, what I want you to further do is to divide this into the phenotype, the genotype, speak about precursor lesions, and then, of course, the immunology that affects. Let's give it a go. Now, phenotypically, or the phenotype, we focus on the skin color, basically. So the more pale you are, the more chances of you getting these skin cancers. Of course, we use a classification called the Fitzpatrick score that looks at the ability to turn. That is our greatest thing. There is also another score which we'll use, is the Glagau classification, which focuses on photoaging. Therein, we then divide into mild, moderate, I think advanced, and then severe. And then we'll scale them. And of course, wherever you have severe photoaging, you are more predisposed to getting skin cancers. Now, looking at the genotype, this looks at the genetics. Mutations mainly here in the patched gene, which is the PTCH gene, coding for the sonic hedgehog signaling pathway. These are some of the things that we've identified. For UV radiation, we've also picked up issues with the tumor suppressor genes, which is the P53 gene. So these are some of the things, but we are certainly not so sure. There are conditions which are associated with this now, genotypically. These are xeroderma pigmentosa, that's one of them. XP, very rare condition, but we see it quite a lot in our population. It's an autosomal recessive condition, and in essence, there's just an impaired DNA repair mechanism, your thymine dimerizase problems therein. We have other things like albinism, which is something that's also quite common, ocular cutaneous albinism. And that's divided mainly into 4 types, type 1 up until type 4. And in essence, what it is it's a defective production of melanin from tyrosine. So, example, type 1 will be tyrosine dependent. So, in other words, it will involve this enzyme called tyrosinase, which will be affected, whereas in type 2, you find normal levels of tyrosinase. There's another syndrome which we call Gorlin's syndrome. You do not need to know too much detail about Gorlin syndrome. The other name is Nevoid Basal Cell Syndrome, and it's more an autosomal dominant condition. And there's a huge diagnostic criteria where we look at major and minor diagnostic criteria. So in order to diagnose it, you just need two major criteria, or you may have one major and two minor. And then there are other things like your porokeratosis, which basically is just abnormal keratinization, and these will mainly also degenerate into squamous cell carcinoma. Now, there are also precursor lesions which you must bear in mind. What are those? Most common is actinic keratosis. Now, this is due to chronic sun damage. And what you find with actinic keratosis is that 10%, there is a 10% risk of malignant transformation into squamous cell carcinoma. That's why we often so curious, and the dermatologist would follow up these patients, have a look at them, and us as plastic surgeons, when they get to a worrisome level, perhaps we then cut it out. There's also cutaneous horn, which in essence, I can just say for your benefit, is very advanced actinic keratosis. Now, we also have other, precursor lesions, such as your nevus sebaceous of Jadasson. Now, these usually you have at birth, usually on the scalp or the face. They usually these hairless, yellowish plaques, but they are dangerous because about 10 to 15% will transform into what? A basal cell carcinoma. And then those bones disease, succinctly put, this is another name. You can just say this is squamous carcinoma in situ. And this has 10% risk, there's a 10% risk of that malignant, transformation into an invasive cancer. Of course, there's erythroplakia, there's leukoplakia, which are most common oral mucosa lesions. And you need to just watch these carefully because there's a 15% risk of transformation also. Keratoacanthoma, quite important, something you can keep at the back of your head because these sort of resemble squamous cell carcinoma histologically. However, they are not really. So what we usually do for those large ones, we just treat them as squamous cell carcinomas and resect them. The last factor under host for risk factors will be immunological. So immunosuppressed patients, just like patients who have AIDS, patients who have renal transplant, patients who are on medication and treatment. Aging is one risk factor for decreased immunity. How do you get that? Usually we know with aging you have decreased mechanisms for DNA repair from sun damage breakage, but also there's a decrease in the mechanism of immunologic surveillance. So that's why aging is a risk factor. There are also environmental factors. Now, those environmental factors, I think we can focus on 4. UV radiation is a big one. UVA, UVB is what we are mostly concerned about. And the reason I can tell you is mainly looking at the ozone-rich stratosphere. It absorbs your any UV wavelength that is less than 290 nanometers, and that's why the ones that get through is your UVA, UVB. We never used to pay much attention to UVA, always afraid of UVB, but UVA is also important. Why? We don't know so much. We think, look, there's an area where perhaps it might potentiate the effects of UVB, but also act as a potential carcinogen in itself. Ionizing radiation is another environmental risk factor. Chemicals, how so? Not entirely so sure. They may have a direct carcinogenic effect, or in themselves they may magnify the deleterious effects of UV radiation. And some of these are arsenic, smoking, we know, with the lips, polycycline, aromatic hydrocarbons are some, and hydrogen, or nitrogen rather, mustard are some of them. And of course, viral, don't forget that HPV has been shown, and there's something called, the term may come to, Lowenstein tumors, which are sexually transmitted, cases where people may get squamous cell carcinoma from that.
So you mentioned Adnexal skin cancers as part of non-melanoma skin cancers.
Yes.
Tell us more about them.
Look, remember we spoke about the skin. I told you about the anatomy, and I told you in the dermis around there, there are adnexal structures. So anything there that we consider those as skin cancers, but they are not so common compared to our cutaneous skin cancers. There are many of them. I just, perhaps, if you can just remember I might tell you about 6. Let's see how much we can go, how far I remember myself. But 6 perhaps of 7 that you should know about, not into too much detail though. Number 1, Meckel cell carcinoma. Very important tumor to know about. If I spoke Afrikaans, I'll tell you they are doodgevaarlijk. Very dangerous. Rare. The primary cutaneous neuroendocrine carcinoma. Remember, Meckel cells are mechanoreceptors of neural crest origin. So these are neuroendocrine cancers of the skin. Now, there's a mnemonic that we always used to use, A-E-I-O-U, but as I grew up, it was I-A-E-O-U. And in A, we speak about A, it's asymptomatic. E, expanding rapidly. I, immunosuppressed patients. O, older patients greater than the age of 50. And then U, of course, exposure to ultraviolet skin. Now, the way you diagnose them, it's a bit difficult because they similar to small cell carcinoma, and they may in themselves coexist with squamous cell carcinoma or basal cell carcinoma. Therefore, these you would need immunohistochemistry, where actually we would look at 2 major things, neurofilament proteins and cytokeratin 20 are usually those things that are distinct to Meckel cell carcinoma. Now, the prognosis is bad. It's worse than the prognosis for melanoma. The prognostic factors, quite similar to melanoma. But these, you understand, you don't want to play around. You want to treat this. And how do we treat it? Wide local excision. 2 to 3 centimeter margin, we agree. There are some who may even say, look, these are so extensive, and in fact 55% of these patients, as we've seen, will have lymph node involvement, and so some may say you may need to do an elective lymph node dissection. I'll just say, for your purposes, just know that we resect them, and we may then use radiotherapy. Chemotherapy is for palliation in these patients, but consider certainly a lymph node dissection. The second Adnexal tumor, maybe you can think, keeping at the back of your head, sebaceous carcinoma. They are rare, but also aggressive, derived from sebaceous glands. The issue with them is the recurrence rate is very high. So usually you will get these yellow or orange plaques, which are usually around the periauricular region. Actually, 75% will be periauricular. And how do we treat them? Wide local excision. That's it. That's all I need you to know. There's also porocarcinoma. We know the eccrine, glands also. Usually we find these quite a lot, or more associated rather, with the elderly patients in the lower limbs. they grow very slow, and lymph node metastasis, or rather spread, is rather infrequent. So they're not as bad as the previous two we spoke about, your Meckel and sebaceous. There's also something called extramammary Paget's disease. Now, we think, that we're not sure. What we think is that they are of apocrine gland origin, but there is much debate that you should know about. Classically, in the perineum, wide local excision is important, but high rates of recurrence, up to 50%, will recur. And then the last one, maybe you must know, I think we're on number 5, or number 5 or 6, probably number 5, is microcytic adnexal cancers. Head and neck, usually around those areas, older patients, slow growing, recurrent, but they are rare. There are other cancers, of course, your pilomatrix cancer, your malignant chondroid syndrome, your hydradenocarcinoma, eccrine spironal carcinomas. Those are just things that maybe you can remember to mention. But if you can remember Meckel cell, sebaceous, porocrine, extra mammary Paget's, microcytic adnexal cancers, I'm a happy man. I think those are the main ones that you need to know about.
Thank you for that. So now let's discuss the more common pathology. Tell us about basal cell carcinoma.
A basal cell carcinoma. Okay. Look, allow me to work with the assumption that we've diagnosed this patient. So we've taken our history where we've looked at the risk factors that affect the patient. We've made a diagnosis looking at the lesion clinically. We are worried about it. We take a biopsy, we get a result, and it says basal cell carcinoma. So whenever we speak about cancer specific, we'll always look at the epidemiology. You want to know about the biology, where does it origin, and the etiology of the tumor. Subtypes are important, and then your management, mainly the immediate, and how you manage recurrent lesions and how you follow up these patients are important. So let's speak about BCC. Now, epidemiologically, this is the most common skin cancer. Now, it is about 4 to 5 times more common than squamous cell carcinoma, and it is almost exclusively in light-skinned people. That's quite interesting because certainly in our experience, we've picked up some cases that were in a black population. However, whenever I see it in a black population, I always question it. And if you send it back to the pathologist and they look further into it, they actually have picked up in the ones that we've sent back that it's not BCC. So I can say up to now, I have not seen it in anyone who is of a black population. However, you may get it. Now, more than 80% of them are in the head and neck region. Within the head and neck region, majority are on the nose. In fact, it is the most common eyelid cancer that you get. Biologically, it originates from pluripotent epithelial cells of the epidermis and also the hair follicles at this, the dermis, the demo-epidermal junction. That's where we have them. There's that strata basali, which we spoke about. And we are unsure really about the pathophysiology. We've seen acquired mutation in the PTCH1, which is the receptor for the hedgehog sonic protein. That's been associated with xeroderma pigmentosa, sporadic basal cell carcinoma. We've also seen the importance of other, proteins, COX, cytochrome P450, vitamin D receptors. So we are uncertain. However, what's important is the origin, which is that dermoepidermal junction. Now, this cancer, there are 26 types of basal cell carcinoma. We're speaking about the histological pattern, of course. 38.5% are even mixed. So there's so many of these, but perhaps we can focus on 6 that I would like you to know. Nodular, which is the most common, about 50 to 60% of the patients, predominantly on the face. These may be ulcerated, mind you. Ulcerated in the sense that they'll have these rolled out borders, and the central ulcer that is so that shares resemblance with a rodent ulcer, and that's why they are known as rodent ulcer. Now, incidentally, while I'm here, I actually performed a study myself where I looked at rat bite injuries in 56 children, and I was able to bring the first classification, world classification of rodent or rat bite injuries. And the moderate injuries, the ones that we found predominantly, looked exactly like these. We call these the rodent ulcer. Now, enough of blowing my own horn. The next will then be your spreading. That's the next common. About 9 to 15% of patients will come with this spreading subtype. Now, this involves the epidermis only. And that's why it may be at times confusing, because it can get mistaken for you, things like your fungal infection, your actinic keratosis. And so these predominantly, you would find them on the trunk. Your next common would be your micronodular, 15% of patients, and these are just round, small nodules that look, like small hair follicles. And then there's also a type called infiltrative in about 7% of patients who present with these opaque yellow-white lesions which have variable sizes and jagged edges. Then another subtype is pigmented subtype. That's about 6% of patients. Now, they derive the pigment from melanoma. Now, what's interesting is that these are often then confused for melanoma, because it's easy to confuse them because of their pigmentation. The last one that I think you need to know about is morpheoform or sclerosing or fibrotic. It's about 2 to 3%. Very aggressive. In fact, they present as almost this enlarging scar with no history of trauma whatsoever. There's a high incidence of positive margins for this tumor. And so these are the ones that are of high risk, and we should worry then about.
Wow. So are you saying even if you operate these subtypes, you can't get all the cancer out?
Look, not necessarily. What I mean is that due to its manner of growth and clinical appearance, there's an increased chance that after cutting it out, you will have positive margins or recurrence thereof. Look, generally, when we look at basal cell carcinoma, about 30 to 50% will recur within 5 years. Now, the metastatic rate is very low. It's about less than 0.1%. But the patients that will recur, or rather, let me put it this way, the risks for recurrence usually, and incidentally, I've done a study on this. One of my research was on this, to look at the factors that were associated with incomplete margins and recurrence. And generally what we find is it's operator dependent. So the operator experience, the anatomical sites, of course, head and neck, there's greater recurrence than your trunk, your histology subtype, your excision of multifocal tumors that are coming, that you are doing during the one procedure. So these are some of the things that will alert you. Therefore, these you would like them to be treated differently compared to then the others.
Okay, let's talk about treatment.
Okay, look, I think when it comes to treatment, what you want to do is divide your patients into two groups: those with high risk and those who are low risk. High risk speaks about all those issues we spoke about when we spoke about the risk factors. So it's your poor prognostic factors. It looks at the depth. Some would say Breslow more than 2 millimeters. It looks at your infiltration. Is the perineural invasion, lymphovascular invasion. The anatomical side, of course, as we've mentioned, in the central phase, the behavior of the tumor, the biology, its invasiveness, the differentiation, the subtypes. We said morphoform, quite dangerous. The size, which we are slowly moving away from. Historically, would say, look, if it's more than 2 centimeters in the trunk or more than 1 centimeters on the face. Further would say if it's on the central face and more than 6 millimeters, those ones are high risk. But in general, the principles, you want to divide your tumors because that will inform your management. Now, the treatment options or modalities that you have are 3: medical, destructive, and surgical. Medical, what we speak of, are those topical agents that you will put on the wound, you see. So, and usually reserved for, if surgery or radiotherapy is contraindicated or impractical, then we'll do it. There are those who will say it is effective for multiple low-risk superficial lesion or things like Bowman's disease, which is your SCC in situ. I'm not really too great a fan of them. Options are Aldara, which is imiquimod, 5%. There's 5-fluorouracil. What we use is Efudix. There's 3% diclofenac gel, your Solaraz, which you may use in patients who are less compliant with your Aldara and 5-fluorouracil. Other options, it's radiotherapy. You may use it primarily, usually for non-operable patients where surgery is contraindicated or age more than 60 years old, or as an adjuvant treatment for high risk, with perineural positive margins. If you have positive lymph nodes, you may then consider this. There is also new things that are being used, your hedgehog pathway inhibitors, such as your vismodegib, vismodegib or vismodegib, potato. So that's one of them that you may use in order to assist you. There are destructive options. So what we are doing, we are destroying this tumor. How do we do so? Curettage and electrodesiccation. Basically, in curettage, you remove the visible tumor, and with your desiccation, you remove the residual malignant cells. So it tries to burn them. Your cryotherapy, where you cool the cells, your tumor cells, to minus 40 degrees in order to then destroy them. There's laser phototherapy, where we use our CO2, pulse CO2. But what you must know is that the depth is limited to your papillary dermis. And also there's photodynamic therapy that you may use. Not too big a fan. The problem with all of these, what? You don't have a histological sample. So you've burnt this, but you cannot prove that it's completely out. The only way you can prove is through your surgical options, where you cut it out, you send it to the lab, the results come back and say it's completely out or it's not completely out. So surgical options is what we then tend to favor. For low-risk lesions, the margin you'd follow is 4 millimeters. For high-risk lesions, you're looking at about a 10 millimeter margin. We're happy with that. Now, the gold standard is, of course, by far Mohs micrographic surgery, which has a 99% cure rate. Now, what is this? Is when you go into theater, you go in with the pathologist, you take small sections, they look at it under microscope, they say cut more, you go and cut up until you've got a clear margin, and then you can do your reconstruction there. You've dealt with the patient 100%, rather than resecting, sending it, getting a histology, and then having to go back and operate the patient. But due to limited resources, due to the technical expertise and the expenses thereof, we then limit it to special circumstances. So there are indications for Mohs micrographic surgery, which are a recurrent lesion, cosmetically sensitive areas, different subtypes, which spoke about that morphoform, poorly delineated margins where you can't really see, and poor biology thereof. And of course, the last thing that you can then look at is then your adjuvant treatment that you can then use.
So how long do you follow up these patients?
Now, generally, look, for BCC, 6 to 12 months, where you will examine the patient. And what you want to do is then, educate the patient. It's about sunscreen. It's about self-examination. If you do find a recurrence or incomplete excisions, which are about 4.7%, treatment is rather controversial. You can do one of two things. Some will say, look, let's go. This is an indication for Mohs micrographic surgery, which I agree with. Others will say, look, you can cut it. You can take a margin of 5 to 10 millimeters as per the UK guidelines, which follow an article by Berg in 1975. You await a histology, it comes back negative, and then you reconstruct. That's also fine. And then, of course, others will say, no, just go for radiotherapy. If it's still recurrent after radiotherapy, perhaps look at systemic treatment with hedgehog pathway inhibitor. So those are your options and your follow-up period for these patients.
Thank you for that elaborate explanation. Shall we talk about SCC now?
Okay, no, let's go through it. Squamous cell carcinoma. Let's follow the same the guideline or the way we did it with BCCs, where we look at the epidemiology or biology, and then maybe how we then manage it. It is the second most common cancer, usually second to BCC, in sun-exposed areas, so you'll see it on the face, your hands, your forearms. And this basically arises from the Malpighian layer, which is that layer in the epidermis that takes in your strata basale and granulosum. The difference with basal cell carcinoma is that this is more aggressive. Now, it also is able to spread to lymph nodes. That's different. And also there's hematogenous spread that may take place, where it may spread to lungs, to the liver, to the brain, to the skin, to bones. So that's the one thing that is a bit of a problem. Now, as per the lymph nodes, what you will usually see is that in about 35% of the patients, they will have lymph node spread. But what is interesting is that 35%, there's rather a 35% 5-year survival despite doing a lymph node dissection. So of patients who present with already lymph node metastases or spread rather to that site, you must know that 35% of them, there is a 35% 5-year survival, even if you do a lymph node dissection. And most of these deaths, interesting enough, are secondary to ear lesions. So for these, you want to make sure that you cut them out, because recurrence is high. I mean, the 3-year cumulative risk of a subsequent squamous cell carcinoma after an index 1 is about 18%. And so you follow then the predictors of recurrence, as we've mentioned, which are quite similar to the basal cell carcinoma. Your cell differentiation in this case is quite important. In that, look, for lesions that are well differentiated, there's a 7% recurrence, moderately 23%. Poor differentiated, you're looking at 28%. The depth is quite important, especially if it goes to the reticular dermis or the subcutaneous tissue. It's quite dangerous. In fact, some literature would say a penetration of greater than 8 millimeters is associated with an increased death rate. Of course, perineural invasion, desmoplastic squamous cell carcinoma, and if you look at a meta-analysis, in fact, that was taken out by Thompson in the JAMA Dermatology 2016, what they said, they focused on a Breslow of more than 2 millimeters, a size, they looked at the size and the site which came through, also mentioned in the HACC guidelines, of the lip, the ear, and the temple, of being those tumors that are likely to then recur. So these are what you should keep an eyesight, or a close eye rather, on.
Do we also have subtypes of SCC?
You see, SCC, and that's an excellent question that you ask. I'm glad you did, because SCC is quite unique. Now, all types of SCC are histologically similar, with irregular masses of squamous epithelium proliferation with downward, infiltration towards the dermis. Now, the way we grade these will be based on the degree of differentiation. Now, what do I mean about differentiation? Now, this is a measure of the ratio of atypical pleomorphic and anaplastic cells that you take as compared to the normal epithelium. And then you will look and say, no, this is well differentiated compared to that. This is moderately, or this is poor differentiated. So we don't really have subtypes. But what we can look at is that we have squamous cell carcinoma in situ, and we have infiltrative squamous cell carcinoma. We know the one in situ, we've spoken about it, Bones disease, which is asymptomatic. It's well demarcated, these scanty patches that you get in the penis. There's a term, the erythroplasia of Quarat is what we call them if it appears in that area. Invasive, of course, we spoke about it. You say well differentiated, moderately, or poorly differentiated. That being said, there are other variants. Your varicose, which is low grade, usually in the palms and soles of feet. We're not sure if it's secondary to trauma or chronic irritation or infection. There's also your ulcerative, which is quite aggressive, and the ones you find underneath the nail beds, which is subingual. So those are just to keep. But I think if there's one important one you must remember, is something called a Marjolin's ulcer. Now, this is usually an ulcer that is secondary to chronic inflammation or injury that develops over many years. In fact, the average is 32.5 years that this then, takes. But this is more associated with burns that are raw, that were not grafted. And with that, it carries a 2% lifetime risk of malignant transformation. Therefore, for these patients, you must have a high index of suspicion. So if you see a chronic wound that suddenly has these unexpected changes, it may be pain, it may be odor, or it's discharging, you want to biopsy these because these are aggressive. Why are they aggressive? We're not sure. Maybe they are biology or the late presentation of patients. But for these patients, you want to take an incision or a wedge biopsy on the edges, on the center, which is very good to diagnose. You have a less than 2% false negative rate. And if it comes back as SCC, you do a wide local excision and a skin graft. There may be times where it's extensive on the limb, requiring limb amputation. But generally we'll do that. And if we palpate lymph nodes, we'll do a lymph node dissection. Radiotherapy, chemotherapy, really poor response to that. Why? Remember, the vascularity we suspect is the problem. And you have this fibrosis, and so it doesn't work so well. So we reserve radiotherapy for palliative then cases.
How do you treat SCC?
I think we can approach it the same way as we did with basal cell carcinoma. There's medical, there's destructive, and there's surgical. Medical, radiotherapy, there's data that tells you there's a 90% cure rate. There's chemotherapy that you may use as an adjunct for larger tumors, recurrence, metastasis, and we generally would use cisplatin with or without 5-fluorouracil. And then there are destructive options, which are your curettage, electrodecussation, your cryosurgery for small superficial lesions. But remember, and I will always make this point, the disadvantage, you don't have histology to confirm. Therefore, surgical is still the mainstay of treatment. The first being excision with a wide local margin. Now, remember I said we divide them into low risk, high risk. So the margin that you are going to use for this is if it's less than 2 centimeters, it's grade 1. There's low risk regions or anatomical regions and the depth limited to the epidermis. Those ones you want a margin more than 4 millimeters. We are happy. However, if it's more than 2 centimeters, the grade is 2 to 3. 2, 3, or 4 grade. It's a high-risk lesion, squamous cell carcinoma, that goes down to the subcutaneous depth tissue. Those ones, you then definitely want to do a 6 millimeter resection margin. Now, we spoke about most micrographic surgery as being the one that is the gold standard. It remains the gold standard for these. The indications are the same. Remember, we went through the indications. We spoke about the cosmetically sensitive areas where we will focus on, the recurrent lesions and areas that we are quite worried about, and the subtypes. So here, if it's infiltrative, we may then opt for Mohs micrographic surgery. How do we treat lymph nodes? If it's high risk and there's no palpable lymph nodes, you do a sentinel lymph node biopsy. If the sentinel lymph node comes back positive, you go back and do a lymph node dissection. If initial examination you have positive lymph nodes, you do an FNA and histologically they are positive, you do a lymph node dissection. Look, there are some who may say elective lymph node dissection. These, I would say, let's limit it to 2 situations. If on the head and neck, it extends to the parotid capsule, and if it is in this contiguous basin, in other words, neighboring to a lymph node basin, then those patients are the patients that we will then do a elective lymph node dissection for. So the question you may then ask me would be how we follow up these patients who have SCC. Where, remember, when we speak about follow-up, the most intensive period is the first 5 years. And so for local disease, what we want to do for the first 2 years, we will follow these patients up with our examination, looking at the lymph nodes. For the first 2 years, 3 to 6 months. Then 16 to 12 months for the next 3 years. And then annually thereafter. For regional disease, the first year, 1 to 3 months. Then 2 to 4 months for the next year. Then 4 to 6 months for the third year, and the subsequent 3 years. And then lastly, then would follow them up for 6 to 12 months for the rest of the lifetime. And what would we do? We would then do patient education about sun protection. You want to teach them about self-examination so that they are better able to take care of themselves.
Thank you for your time, Dr. Ngwenya. Any take-home message?
I think we've had quite a lengthy discussion, and I'd say to take home, let's remember principles. Principles is what matters. Skin cancer is common. if you get a patient with skin cancer, you want to divide it into melanoma or non-melanoma skin cancers. Non-melanoma skin cancers, you divide them into adnexal, which are rare, or cutaneous, the most common of which are basal cell carcinoma, followed by squamous cell carcinoma. Then you diagnose a patient by looking at the history, wherein the risk factors are important. And then you examine them and you biopsy the lesion. And when you get a biopsy, it then comes back and gives you the diagnosis and subtypes. With all that information, what you then want to do is distinguish, is this a high-risk lesion or a low-risk lesion? This will dictate the extent of the treatment that you are then going to provide. And the treatment options that you have, it's medical, it's destructive, it's surgical. Note, medical and destructive, we have no histology, so no certainty. With surgical, margins is what matters. So you look at low risk, high risk, and then use the right margins. You then go for Mohs micrographic surgeries, if indicated, as it is our gold standard. Lymph nodes, we've spoken about them. If they are positive, you dissect them. If it's high risk and they are negative, you then do a sentinel lymph node biopsy. And then, of course, there's adjuvant treatment that you can look at when it comes to the high risk or the low risk. And follow up, the 5 years is the intensive period, and then you then follow up annually for the rest, teaching the patients to take care of themselves, sun protection and self-examination being the main thing. I hope this will assist you in understanding basal cell carcinomas, squamous cell carcinomas, and adnexal cancers as this group of non-melanocytic skin cancers, and it adds value and assists you in treating the patients. Thank you very much for your time.